Hello. It's my pleasure to introduce Dr. Osama Hamdy. Uh, he is he's a senior endocrinologist, medical director of Jocelyn Obesity Clinical Program, director inpatient diabetes program at the Jocelyn Diabetes Center. He's also the associate professor of medicine at Harvard Medical School. Dr. Osama Hamdy will be speaking on 10-step roadmap to type 2 diabetes, when and how to break the cycle. Dr. Hamdy, you can start sharing your slides.
Okay, can you see it now?
Yes.
Okay, very good. Hello, everyone, and welcome back again. I hope you enjoyed my first presentation. And I believe this one will be very, very important for all of you since it has a lot of practical implication on your practice. Most of us know that people develop type 2 diabetes, but many of us don't know that there are 10 steps that patients go through until they develop type 2 diabetes. And recognition of those steps may be very valuable in breaking the cycle to type 2 diabetes or even reverse diabetes. So let me start from here. We know the puzzle of type 2 diabetes now, and the puzzle is beta cell dysfunction and insulin resistance. But a lot of us are asking when this insulin resistance occurs. It occurs before beta cell dysfunction, or beta cell dysfunction occurs first, or both of them occur at the same time. So if we look to the progression to type 2 diabetes, when people are overweight and obese, you will see that they get first insulin resistance for the rest of their life, especially if the weight is still the same. And as you can see, there is a period that beta cell is trying to compensate and trying to overcome that resistance. And during that period, there is an area, or I would say a duration, where diabetes can be controlled very well. And there is another period when beta cell dysfunction or even failure is at maximum, and it is very difficult to control diabetes. That's the old concept that we have. But we never ask it ourselves. To the maximum, we'll be able to reverse the diabetes and return the clock back and improve beta cell dysfunction and induce remission again. So this is a very, very important point, and would like to answer this in this presentation. So to understand the whole scenario between beta cell dysfunction and insulin resistance in the development of type 2 diabetes, we have to understand that this passes, as I mentioned, through 10 steps. So let me start with the first step. The first step is someone has a family history of diabetes. If you have a family history of diabetes, this is the strongest risk factor for development of type 2 diabetes, especially if it is from a first degree relative, and especially if it is from both parents, not from only one of them. Definitely the risk will be higher. And when people advance in age, the risk becomes higher and higher. So this is the first step. Someone has family history of diabetes. So what usually happens in the second step is a slight weight gain. The person, as you can see in this box below, becomes overweight, and I will put in that box what comes in as a phenotypic and biochemical. So the person gain slight weight, usually around 2 to 4 kilograms, and usually between the age of 20 and 30, because the metabolism starts to shift toward less burning of calories during that time. And especially when the accumulation of fat occurs in the upper half of the body. So we know that there are two ways of weight gain, or two phenotypic of weight gain. One is below the waistline, this is a pear shape, and the other one is above the waistline, which is an apple shape. And that phenotype is what is usually is associated with type 2 diabetes, accumulation of fat above the waistline. So slight weight gain occurs. And because weight gain is and weight control is very sophisticated mechanism, you will be surprised to know that there are 34 neurotransmitter and hormone in your body that control body weight. So any disturbance in these hormones at that stage can lead to weight gain, but in the same time, the balance between all those hormones and transmitter is very important. Now, that person gained weight and have more tissue. More tissue definitely needs more fuel, more glucose. So pancreas, which is still at this stage in healthy scenario, it is hypertrophied because the person gained weight, and the pancreas at that time secretes more insulin. So this is a stage of hyperinsulinemia. If you measure insulin, if you measure C-peptide, they are high, but you have to remember, until this stage, the body is still insulin sensitive. So if you are insulin sensitive and you have high insulin, what will happen? What will happen is that there will be an accelerated weight gain because insulin is a growth hormone, and the growth effect of insulin can lead to 5 to 10 kilogram of weight gain within a very short period of time. So over maybe 6 months, the person starts now from a slight weight gain to accelerated weight gain, significant increase in body weight. And this can be a very, very nice marker for you, clinical marker. If you ask the good history and you know that there is a period of significant weight gain. So now still the body is insulin sensitive, and still insulin and C-peptide are high at that stage. So if you measure them, they are still high and the person gained a lot of weight. What fuels this stage is eating carbohydrates. So during this stage of hyperinsulinemia and normal pancreas, eating carbohydrates with fat can be a problem because carbohydrates stimulate pancreas to secrete insulin. Insulin is a growth hormone. As I mentioned, stimulate lipogenesis and take the fat and store fat inside adipose tissue. But because the body is still sensitive to insulin, insulin brings blood glucose down. This is what's called the reactive hypoglycemia. The body is not resisting insulin at this stage. The body is still gaining weight. High insulin level make that person hypoglycemic. So in 3 hours, that person start to be hungry and start to eat more. And definitely, if you have hypoglycemia, you will eat more carbohydrates. And then this cycle keep going on every 3 hours. The person eat carbohydrates, store fat, gaining weight. And as you know, carbohydrates also increase triglycerides, lower HDL, and the person starts now to get insulin resistance. But what is also interesting, insulin itself is a salt and water retaining hormone. So blood pressure starts to go up. Then you have now the perfect storm. You have big waistline, you have higher glucose, higher triglyceride, lower HDL, higher blood pressure, and this is what we call it cardiometabolic syndrome. And that's why people die in diabetes. 65 to 80% of them die from cardiovascular disease. So now we know, and at that stage, definitely carbohydrates is a big issue. In the old days, before the discovery of insulin and any other medication, people understand it very, very well. Even they define diabetes as carbohydrate intolerance disease. There's an article which I published in New York Times in 2016, talking about old-fashioned way to treat diabetes, a better diabetes treatment. And I said that by far nutrition is the most effective way to prevent and manage type 2 diabetes. But it's very interesting that when people start to gain weight, And especially when that weight gain is around the central area, they become more insulin resistant. And as in different ethnic group, like in the Middle East, like in India, people have tendency to accumulate fat around their waistline, even if they don't gain much weight. So people start now to be more insulin resistant. But different types of fat in that area around the belly is responsible. You know that there is subcutaneous fat, which is not that dangerous, and then the intra-abdominal fat, which again, it is 1 to 2 kilograms of fat accumulated in the intra-abdominal area, in the visceral area. This is a fat that when people gain weight can cause big problem for them. So why this happens? The body, as I mentioned, start to resist insulin because too much insulin can cause significant damage. So liver, muscles, adipose tissue start to be insulin resistant. Waistline is going now up and up, and still at this stage, the C-peptide and the insulin are high. But we have now an additional period of insulin resistance. I wrote a review article several years ago about how to measure insulin resistance in clinical practice and in clinical research. But this is again, very important step. Now, at this step, if you help people with insulin resistance, whether they have diabetes or not, they have pre-diabetes or diabetes, or even just obesity, to lose 7% of their body weight, insulin sensitivity improves by 57%. This is a huge opportunity at this stage to prevent diabetes or even to reverse early diabetes. So now, here is the beginning of the major problem. As you all know, insulin stimulates lipogenesis and suppress lipolysis. But what happens here is that visceral fat, selective escape of visceral fat from that suppression of lipolysis. So the body is still gaining weight, but that whole area in the abdomen and the visceral fat escape from lipolysis. And when it escapes from lipolysis, it starts to shower the body with free fatty acids coming from visceral fat. And this stage is characterized by inflammation. This is subclinical chronic inflammation. There are many markers of this inflammation like TNF-alpha, IL-6, CRP, MCP1, BI1. If you measure them at this stage, you will find that all measures of inflammation are high. So what happens here? We wrote about this theory before, which had been proven to be correct, the Adipokines Theory, and we mentioned that from 2003 and then 2005. So when people start to accumulate visceral fat, we usually see increase in markers of inflammation, and especially TNF-alpha. On the other side, you have an opposing cytokine, adiponectin, which usually goes down in that scenario. So cytokines, inflammatory cytokines are going up and adiponectin is going down, and this could be the reason for insulin resistance and atherosclerosis. Endothelial dysfunction is a very early stage of atherosclerosis. So what happens? We thought initially that those cytokines are coming from the fat cell, but we discovered, and many other colleagues discovered, that it comes actually from, or they come from macrophages. And you can see around the fat cell, there is a lot of macrophages, as you can see. These are called adipose tissue resident macrophages. So how the macrophages came to this area in the adipose tissue? So as you know, in adulthood, you don't differentiate too many fat cells, but the fat cell continue to accumulate fat. But fat cell has limited capacity to accumulate fat. So when the fat reaches certain limit and the fat cell size reaches certain limit, apoptosis of the fat cell occur. So necrosis of the fat cell cell membrane occurs, and debris of the fat cell attract macrophages, coming to clean the debris and phagocyte the debris of the fat cell. And as you can see, on the plate of every large fat cell, you can see the macrophages sitting here. So here is a scenario now. Fat cell in the visceral area get bigger and bigger. Fat cell die, attract macrophages, and macrophages start to secrete inflammatory cytokine, TNF-alpha, IL-6, and MCP-1, which attract more monocytes, and then PI-1, which is related to cardiovascular disease. So what those are doing, this is very interesting. TNF-alpha stimulate glue on the surface of endothelium. This is what's called adhesion molecules, intravascular and vascular adhesion molecules, where monocytes get attached to them, and TNF-alpha stimulate penetration of the macrophages through the endothelium, which now engulf, oxidize the LDL, and become larger cells called foam cells. Cells that are full of fat, and from these cells, the atheromatous plaque is formed. And in the same time, TNF-alpha stimulate narrowing of the blood vessel by smooth muscle proliferation and migration. IL-6 help that process. MCP-1 attract more macrophages. And when the plaque is mature, another cytokine, MMP9, is a proteolytic cytokine, and the plaque rupture and people get heart attack. So you can see that scenario is going hand in hand with the increase in the amount of visceral fat and the showering of the visceral fat of the body by those inflammatory cytokines. So now what happens in the visceral area? More lipolysis, so people stop gaining weight in the central area, but continue to gain weight in the periphery. So this is a period of a slower weight gain. So we have a slight weight gain, accelerated weight gain, insulin resistance, escape of visceral fat, and then slow now weight gain in the central area. But that fat, which in the visceral area, as I mentioned, shower the portal circulation with extensive amount of free fatty acids. So what these fatty acids will do? Fatty acids now will go to the liver. This is where we started the fatty liver, which is very, very common in people with type 2 diabetes. But also free fatty acid attack pancreas and cause beta cell dysfunction. So now, when beta cell dysfunction occurs, now the insulin is no longer high, it starts to be normal or even low. And then if you measure serum free fatty acids, you will find them significantly high. So this is a stage of lipotoxicity. This is a very dangerous scenario, because what happens after that scenario, beta cell is not functioning very well, blood glucose start to go up, fasting and postprandial blood glucose start to go up. And if this stage is not treated well, it leads to what's called glucose toxicity. So at this stage, you will see now added here hyperglycemia. And in some instances, we need to even use insulin in severe cases of glucose toxicity. Now, the final step is a full picture of the disease. Now, aggressive intervention, as I mentioned, before further damage of beta cell is needed, because this will continue to occur by glucose toxicity and lipotoxicity. And as I mentioned, insulin sometimes is needed. So you can see now the full picture. There is obesity, there is normal low fasting insulin, or sometimes still a little high. There is insulin resistance, there is subclinical inflammation, there is high free fatty acids, and high blood glucose level. So any person stay in every stage at different duration. Could be shorter, could be longer, but it gives you a very nice chance to intervene during that stage. If you be able to understand and comprehend the clinical and biochemical indicator of each stage, recognition and treatment will be very precise toward reversal of diabetes and improvement of diabetes. So let us see how this happens. If you need to intervene and reverse type 2 diabetes, you have to recognize each of the 10 steps and take action. For example, if you have family history of diabetes, try to avoid gaining weight, because gaining weight and getting older is two factors that can lead to type 2 diabetes. So you cannot prevent age, but you can prevent weight gain. At a slight weight gain, aim for weight loss. Don't let the 20 or 30 years of age to lead to those slight weight gain, especially if you have family history. When you have hyperinsulinemia, prevention can be effective if this stage is diagnosed. Very, very important. Accelerated weight gain is definitely the optimal time to know that you are coming to a catastrophe, and this is the best time for optimal weight loss. If you diagnose insulin resistance, you know that you are further in the disease process, but still a precise prevention time if diagnosed. Now, escape of visceral fat is difficult to diagnose, but you can measure free fatty acids, and you can ask about the slower weight gain that will happen, especially in the central area. If you take careful history, you will know. Lipotoxicity, dangerous situation, and at that stage, definitely interaction or intervention should occur. Hyperglycemia and glucose toxicity need mostly aggressive therapy to preserve beta cell. If you intervene during lipotoxicity and severe hyperglycemia, you can preserve as much as you can of the beta cell function. And then finally, if you have the full picture, still you have 5 years where insulin is relatively high still to some extent. This is a glorious period to reverse diabetes. Weight loss, either by medical weight loss or surgical weight loss, can be very effective in this stage. So we have many proven effective ways of managing type 2 diabetes at different stages. Like, for example, as I mentioned, in accelerated weight gain period, medical or surgical weight loss can be very effective. When insulin resistance occurs, give metformin, and that's why metformin was also effective in prevention of diabetes with weight loss. In the stage of lipotoxicity, insulin is a lipogenic hormone, so clear the circulation from free fatty acids. TZD proliferate newer fat cells through stimulation of PPR gamma, and then this will accumulate more free fatty acid. Sulfonylureas stimulate insulin and help in clearance of free fatty acid in the same way. Now, when you have hyperglycemia and glucose toxicity, we know that SGLT2 inhibitors can be very valuable in eliminating some of the glucose from the circulation and clear a big part of the glucose toxicity. GLP-1 is a very efficient medication in the very early stage when there is accelerated weight gain and full picture of the disease. So it looks like a combination between metformin, SGLT2 inhibitor, and GLP-1 analogs, and with addition maybe sometimes with a small dose of sulfonylurea or TZDs, or even insulin if needed in the process of glucose toxicity. So let us now quickly show you what will happen with every parameter that you can see in relation to weight loss. So blood pressure, just 5% weight loss will reduce systolic and diastolic blood pressure by 5 millimeter mercury each. 5% weight loss will increase HDL by 5 milligram per deciliter and reduce triglyceride by 40. If someone has pre-diabetes, 5% weight loss can reduce chance to develop diabetes by around 50%. If someone has diabetes and 5% weight loss occurs, it will reduce A1C by 0.5%. Sleep apnea, 10% weight loss is needed to reduce apnea episodes by almost 50%. Mind that 70% of people with type 2 diabetes have some degree of sleep apnea. Arthritis, Again, 5 to 10% can reduce the mechanical force on the kidney 7 times by weight loss. When weight loss occurs very early in the course of diabetes, you can expect partial, complete remission, or even major improvement. 21%, as you can see in our publication, have improvement, significant improvement, and even remission or complete remission. So to finalize all of this, let us look to the 4 components here of insulin resistance: visceral fat, lipotoxicity, inflammation, and glucose toxicity. So now, non-surgical weight reduction reduce visceral fat. Exercise also reduce visceral fat. Bariatric surgery reduce visceral fat and intrahepatic fat. Very low calorie diet decrease lipotoxicity and also reduce visceral fat. If you give testosterone to people with low testosterone or growth hormone, which is not used in practice, visceral fat also respond, and visceral fat goes down with testosterone treatment. Low carbohydrate diet, and I mentioned in my first presentation why low carbohydrate is important, and you can see with lower carbohydrate, visceral fat goes down, and glucose toxicity, because glucose toxicity is all related to carbohydrates, and as I mentioned, beta cell dysfunction. Metformin can improve lipotoxicity, as I mentioned, because metformin increase fatty acid oxidation inside the liver. And then, as I mentioned, TZDs, insulin and sulfonylureas has a role in lipotoxicity, but the fat cell number goes up and the fat cell size goes up to accumulate more free fatty acids. That's why people gain weight. And then you have we have trial with high dose salicylates to overcome inflammation. It improved insulin sensitivity in clinical research, but it is not in clinical practice yet. Exercise reduce inflammation nicely, and also reduce glucose toxicity, because active muscle take glucose independent on insulin. And then, as I mentioned, SGLT2 inhibitor improve glucose toxicity. So you can see that you can attack insulin resistance by many ways to improve insulin sensitivity. If you do all of them, you may return back insulin sensitivity back to normal, and this can be reserved and return back maybe beta cell function in a good way, especially in the very early stages of diabetes. So the take to practice messages. Number 1, progression to type 2 diabetes takes many steps in someone with family history, and this can be reversed in most instances. And intervention to induce weight reduction is fundamental in improving insulin sensitivity. And as I mentioned, 7% weight loss improve insulin sensitivity by 57%. Even 3% weight loss may be enough to prevent diabetes. So 3%, not even 5 or 7%. Very small amount of weight loss can be very effective. Reducing glucose toxicity and lipotoxicity is very important, because if you enter in that stage, there is no way return from in beta cell dysfunction. So you need something to reduce free fatty acids, as I mentioned, many ways, and you need to prevent going from hyperglycemia into glucose toxicity and severe glucose toxicity. And then several medication, as I mentioned, improve insulin sensitivity through different mechanisms, either directly by increased fatty acid oxidation or accumulation of free fatty acid inside fat cell, or by eliminating glucose from circulation. So reversing diabetes is possible, and I confirm this. This is possible, especially in the first 5 years of the disease. With this, I would like to thank you so much for good listening, and welcome any question that you still have.
Thank you so much, Dr. Osama. That was absolutely fantastic. I have a question to ask of you. Since there is insulin resistance and the need for insulin is increased, there is inflammation and there is lipotoxicity. Would it be reasonable to say that to avoid all these 10 steps, a VLCD followed by a maintenance of intermittent fasting with carbohydrate restriction can alleviate most of these issues?
This is actually a very good point. So people who attended my first presentation understand that intermittent fasting is a very efficient way to improve insulin sensitivity, reduce hepatic steatosis, reduce blood glucose level, alleviate glucose toxicity to a great extent. So you are absolutely right. Weight loss and intermittent fasting can be very, very effective in the very, very early stages. And we don't have a study about prevention, but we know for sure if it improves insulin sensitivity and reduce hepatic steatosis, which is, as I explained now, part of lipotoxicity, this may be very effective and it's worth studying in the future.
There is one more question here. Since inflammation plays such a big part in all of these steps, are there any measures by which you can try to reduce inflammation by way of foods or drugs?
Yeah, definitely. You know, inflammation can be affected by many, many ways. You know, for example, and it is need to be studied, but it is very expensive. If you give interleukin-6 and antibodies or interleukin-6 antagonists, this can be one area. High dose salicylates, as we tested at Joslin Diabetes Center, this may be something in the future. But you know, you have some many natural stuff that people can do to reduce inflammation. Like, for example, if you give omega-3 fatty acids in a very high dose, or pure form of omega-3, which is called the resolvin, it improves inflammation to a great extent. Statins has an anti-inflammatory effect. Some other antioxidant like quercetin, which is from blueberry and have some impact on inflammation as well. Curcumin, which is very, very common in India. So that's also can be an anti-inflammatory as well. So there are many, many ways to do inflammation, but we are lacking a lot of research in that area. So we hope in the future there will be a lot of research in that area. But the best anti-inflammatory is weight loss. We found that with weight loss, all the markers of inflammation goes down.
Shilpa, would you like to ask one last question?
Okay, I cannot hear you.
Hear me now?
Yes, okay, now is okay.
Yeah. So in view of VLCD and during the time when person has hyperinsulinemia, is there a relation of meal frequency to hyperinsulinemia, like people who eat a lot of small frequent meals as compared to say two or three moderate sized meals? Does that impact the way hyperinsulinemia behaves?
You are right. The most important is the amount of carbohydrates and the type of carbohydrates. So a smaller meal or bigger meal, if you eat more carbohydrates and high glycemic index carbohydrates and stimulate pancreas, which is still healthy, to produce more insulin, it will be a problem. So that's why I said that what fuel all this accelerated weight gain is the amount of carbohydrates. So whether a smaller meal or bigger meal, the amount of carbohydrates had to be very low and add more vegetables to slow the absorption of carbohydrates.
Thank you. Thank you.
Thank you very much. That was indeed a very stimulating session. And I think thank you very much. And we will take leave and end this particular session here.